And I think stigma and negative stereotypes is what really divides us further. So I actually learned this very quickly in medical school when I did a pediatric rotation. And one of the parts of the rotation, I had the opportunity to rotate to a pediatric genetic lab. And naturally, the question was do you know why you're deaf? No, I don't. Oh, do you have any family members that are deaf? No. And so they would ask, well, do you think it's possible that you have deaf gene? I don't know. So what we did, naturally, with the genetics lab, we went ahead through my blood and sent it out as a research test. It took about 2 months for the test to be processed, and I completely was on it. And I was contacted to come back, meet with the 2 staff members. My first reaction as a medical student, did I do something wrong? And so I get into this room, and there's 2 genetic counselors sitting at a table, both very somber. And so I sit down and say, hello, what's up? And kind of casual. And so the first genetic counselor says, I'm so sorry you're deaf. So I'm like, okay. And then the second genetic counselor said, what she meant is that we got your results back. And we found out that you are positive for connexin 26, which is a common deaf gene. And so my reaction was, oh, cool. And so both of them now are very perplexed. And so they both asked, say, well, it seems like you're okay with it. I said, well, why wouldn't I? I've always been deaf. This is not going to I know why that I'm deaf. Okay? So that experience has been repeated in a variety of different ways where, we experience these sort of stigma, the negative stereotypes. We heard some of that already before. So one of the things I wanted to do for the rest of the talk is talk about how we can actually transform healthcare, especially for deaf and hard of hearing individuals. Some of this actually can be translatable for other individuals with disabilities. But what's really important is that hearing loss can be marginalizing for many of these individuals. So when you think about the spectrum, we have a deaf child. 95% are going to actually be hearing. So there's automatically going to be communication and language barriers within the home. Many of these patients, when I meet them, they even lack basic history, like family history. I don't know about it, just because of that gap. When we go on to later onset of hearing loss, many of them will talk about the loneliness, the social isolation that happens even when they're in the middle of a discussion with families and friends. So we have this marginalization that's happening across a number of environments because it's not accessible. And this also actually impacts how we access health information. So much of what we learn from a health information standpoint is sort of ambient information, incidental learning opportunities, and not formal learning opportunities. These people don't get it. And so we miss out on those opportunities. So unlike many other patients with disadvantaged backgrounds, not surprisingly, for deaf and hard of hearing individuals, they also struggle with a host of health and healthcare disparities. So when we think about profound impacts on one's health and also the ability to access the healthcare system. We think about from a health standpoint, we have done some studies, and by even just having mild hearing loss, your risk for hospital stay goes up by 16%. When we think about from health conditions, having a hearing loss, basically the association of these health conditions, your odds of having diabetes goes up 16% as well. But for cardiovascular disease, it's 48%. For cancer, it's 35%. So these are people struggling with higher burdens in a variety of health conditions. We're finding out more and more. When we think about from a mental health standpoint, depression, anxiety, interpersonal violence, they're often at much elevated risk. Sometimes it's even 2-3 times higher. The problem with that is that they struggle even just accessing mental health. Their providers, the healthcare system, and they're not able to even find accessible services in the community. And so there's already a gap. When we think about for healthcare communication, provider patients, that's often one that a lot of people complain about. There was one study that looked at deaf signers, And only 17% of deaf signers were provided a sign language interpreter when they met with the doctor. Think about that, 17%. What's scary though is that 87% of those providers were confident that they had effective communication with their deaf patients. Probably not true. So we obviously don't do a good job in recognizing that. So what can we do to really transform healthcare for these individuals? I have five different ideas that I would like to present. So the first thing is really making sure we have training opportunities for our healthcare workforce. Just to give you a scale of how little we expose our medical students on how to effectively communicate and care for deaf and hard of hearing individuals. When we look across medical school, there's only one medical school that I'm aware of, up to this point, that requires every one of their students to go through a course to learn how to care and treat these individuals. Only one medical school. That's wrong. So we need to do a better job, and not only just recognizing cues, how to work with these individuals, and the same thing happens for other types of disabilities. The second thing is also patient screenings. So we often think about diabetes, cholesterol screening, cancer screenings, but we also need to think about hearing loss screenings. Hearing loss is common. When you think about a general population, about 15% have hearing loss. When you get up to 70, it's over half already. So screening for these individuals is critically important because it helps to identify those at risk for communication breakdowns. That's going to have an impact on not only a cascade of events, whether they adhere to treatments, whether they're going to have adverse outcomes, or maybe improperly use healthcare utilization. So we need to make sure we screen them. The third thing is universal designs and access. So making sure that what we offer for these patients, there's an opportunity for them to access it. Following universal design principles is important. Some of these things are pretty simple when you think about it, and doesn't require a lot on our end. Classic example would be calling out patient names from the waiting room. Some of these people are going to miss out. Why not make it a policy of going up to the person or give them a vibrating alert? I know some of us do that. The other thing is when we do a health education video, make sure it's captioned. So these are simple things that we can do. The fourth thing is really thinking about diversity in our team. So disability needs to be part of the diversity equation. That's what I strongly believe that. I had one prominent chair of a medical department who, similar to what you heard earlier, told me that I would never be a successful doctor. And this was already in medical school. And also told me that I stole a spot from a hearing individual that would have been a successful doctor. So these are still happening to this day, and that mindset is wrong. But when you think about when we have a diverse team, we're creative in our problem solving, troubleshooting, but we also reflect our patient backgrounds. We are able to relate to them better. We can work with them. We can usually even know what they need and care more effectively for them. The last thing is assistive technologies. A lot of this is actually the burden is put on the patients, but why not flip it around where the assistive technologies is going to be more on our side? Some of it doesn't require a lot of expenditures. When we think about for mild and moderate hearing loss, even using personal sound amplification products, Pocket Talker is an example. You can buy these for about $40 to $100. Only 20% of people with hearing loss are able to get hearing aids. It's a small number, but having these available in inpatient, outpatient settings can be helpful to bridge some of that communication gap. So I wanted to briefly just talk about some ways we're innovating here at University of Michigan for the first one. University of Michigan is sponsoring and helping, not hosting, sorry, but sponsoring a deaf health fair that will be at Madonna University. This is an opportunity not only to engage the deaf and hard of hearing community. Many of them are not able to access community health fairs because it's not accessible from a communication or language standpoint. Our presenters are all going to be signing. We have also a caption service there for hard of hearing individuals. So this is going to be a unique opportunity to engage them. The second thing is Dr. Sasso and our team we already developed a best practice alert that's inserted as part of our electronic health records. So this tool actually prompts primary care providers to ask a single question: do you think you have a hearing loss? That actually has been shown to be quite effective, and not only just to identify people who at that point in time may not have either have not been treated or identified by the healthcare system. And what we found is that, this is part of an NIH-funded study, but we found that by doing this simple prompt, we doubled the identification of people with hearing loss in our patient panel. And so that, I believe, is going to help down the road as well. The third thing is, at Dexter Health Center, we have a deaf health clinic, which is truly an integrated health model, where we have behavioral health specialists and primary care doctors working hand in hand. And this is really, again, to make an accessible, culturally competent care. We have accessible tools. We also we have bilingual providers, and lastly, we do telemedical appointments and also telehealth appointments and video. And so that's another unique opportunity. And then lastly, the Krusty Hearing Research Institute. We are building an interdisciplinary team where we have people from the medical primary care side working with different departments with the goal, again, to identify why there's so many gaps, inequities, why there's higher health burdens, and what are the creative ways we can actually solve them. First of it, we're still in that research mode, but there's also now potential areas where we can translate that out to hopefully a clinical environment. And lastly, you already heard with our previous talk that really the impact of one individual is huge. So when you think about your favorite doctor, favorite nurse, what was special about them? They often took interest in you. You felt like it was you were a priority to them, but also they were willing to listen to you. They were willing to work with you. So again, we have to do the same thing for this community. So that's important. Thank you. Okay, I know there's a couple questions or time. Yeah, go ahead.
Is the University of Michigan considering exam rooms, installing hearing loops in exam rooms where people can wear the coil to boost their hearing device?
Yeah, so you talk about like they often do like copper wiring and do like loop or